Okay, we're broadcasting. Okay, good afternoon, everybody. I'd like to welcome you to our roundtable on cochlear implant surgery in the COVID era. And I would like to say first that, of course, this has been a terrible time globally, and I'd like to acknowledge hundreds of thousands of people, sadly, who've lost their lives worldwide. It's been a very difficult time, I think, for many of us and our colleagues and friends and family. I think we feel hopeful now that we're coming out of the other side and we're beginning to see how we can start to return to normal or the new normal. So the aim of today is to talk about the cochlear implant operation, cochlear implant surgery. What are the issues and what do we need to do differently? My name's Helen Cullington. I am from University of Southampton and I'm chair of the British Cochlear Implant Group. And I put together a panel of people today who have been working on drawing up the guidelines for the return to cochlear implant surgery in the UK. So I'm really pleased today that we have Manohar Bans. Manohar is the Vice Chair of the British Cochlear Implant Group and is also on the British Society of Otology Council. Will Hellier is an executive on ENT UK. Simon Lloyd is the Secretary of the British Society of Otology and has been a previous council member of the British Cochlear Implant Group. And Tim Mitchell is also on the British Society of Otology Council, also the RCS England Council, and is a trustee of ENT UK. So I'm delighted to have these surgeons here today to help us learn a little bit more about cochlear implant surgery at the moment and in the future. So as just some housekeeping things, as you can see as an attendee, your microphone is muted. So if you would like to ask a question, please could you use the chat function and type your question. We may not be able to feature all the questions because we only have an hour today, but I really hope that we'll be able to answer as many as we can. And as you know, we've put some links on the BCIG website. So some of the panelists today will refer you to links, and there'll also be the recording of this webinar available from the BCIG website from tomorrow. So again, thank you so much for taking time out at 5 o'clock on a Tuesday. And I think for me, what I would like to know first is, what is the status of cochlear implant surgeries in the UK at the moment? So we have heard that some surgeries have started, some people are starting to get dates. Simon, do you have a picture of the surgeries that have happened already?
Yes, I've spoken to the three main implant companies in the UK just to get an overall view of what's been going on, and it may not be entirely accurate, but it looks as if there are 7 centres in the UK that have done at least one cochlear implant. They've all been in children, there haven't been any adults, and there's a range of devices that have been used. I think Cochlear have done roughly 10 implants, Advanced Bionics around 9, and Medel 1 or 2. So it's not a huge number. I'm not quite sure about the etiologies of all of those, but I understand that most of them are urgent, and that there are certainly a smattering of meningitic cases amongst that group. In other countries, I'm not quite sure the details of every country, obviously, but Korea and China, I understand, are pretty much back to almost normal practice, if you can say that we'll ever get back to normal practice. America apparently is around 50% of what they would normally do, and some of the European countries, like Germany particularly, are gradually ramping up their activity, although there are some countries that aren't really doing very much, particularly Italy and Spain at the moment.
So that's really interesting to hear. We're just getting started in the UK, but what we need to know really is how people are prioritising the cases. And Tim, I know that you've been involved in the surgery classifications for this. So can you tell us how are cochlear implant cases prioritised in the whole realm of elective surgeries that people are awaiting?
Yes, I mean, it became clear fairly early on that there was going to be a massive reduction in surgical activity in UK hospitals, and what activity was available, there have been many surgical specialties competing for. So the 4 surgical royal colleges came together quite early in the crisis to come up with a prioritisation document in consultation with the 10 surgical specialty associations in order really to help to inform the process of making use of a limited resource. And that really had 4 levels to it. Level 1 was emergency and urgent cases. Level 2, surgery that could be deferred for up to a month. Level 3 for up to 3 months. And then level 4, anything that could be deferred beyond 3 months. Clearly, a lot of the routine surgery that's done, including cochlear implant surgery, therefore was deferred. Cochlear implantation following meningitis was put into level 2, therefore to be done within 4 weeks. And that's why some of those cases have been done during the acute COVID crisis. And of course, now we're starting to think about the level 3 cases, which includes congenitally deaf children who will potentially suffer if they're delayed for much longer. But inevitably, the other cases, and particularly adult cases, which are in level 4, are probably going to be delayed for quite a while yet, I would think, because it's going to be difficult to see us getting back to anything like the capacity for surgical activity that we were before the crisis.
Yeah, I mean, it seems to me with such a backlog really from the past several months, I think I feel very concerned that perhaps adult surgeries, they're going to be waiting a very long time. And I don't know if you probably don't have a feel for this yet. Do you think that adults perhaps will choose not to have their surgery because they're worried about electively going into hospital at this time? Perhaps we don't have a feel for that yet.
I think there's pretty clear evidence for that, that patients have been reluctant to attend hospital for any sort of medical intervention. And I think there's been a clear change in the last week or so as lockdown has been eased, that people are getting out and about more, they're seeing their general life becoming a little more normal, and they're starting to access medical care a little more readily. But I think there's definitely anxiety about the prospect of coming to hospital and the possibility of contracting COVID in the hospital. I'm certainly hearing that. I'm sure others are hearing the same.
Yeah. So I know that we're kind of bandying around the terms mastoid aerosol, and I must admit that I don't particularly understand what that means yet. And what I'd like to know really are, what are the issues specific to cochlear implant surgery? Why is it more risky? What are the actual issues? I know, Will, this is something that you've been looking into a lot. Can you explain to us, please? What is this aerosol thing?
Certainly. Well, Helen, do we have those slides? So in order to talk about the transmission of COVID, we need to talk about, if we can go to the first slide, it tends to be spread by droplets. And droplets are, as we all know, very small drops of liquid. And an aerosol is a suspension of these. So it can either be an aerosol of solid or liquid drops in a gas. One needs to understand that droplet size is important, because anything less than 5 micrometers is a particle, anything greater than 5 micrometers is a droplet. And we don't tend to notice anything less than 40 micrometers, except sometimes you might see on a summer's day where you see the dust in the atmosphere. Droplets less than 100 micrometers are inhalable. And so the respiratory aerosols, which occur due to coughing or sneezing for a patient with COVID, will include a range of droplet size, including larger ones and smaller ones. And the concern about droplets is that viral particles may contaminate these. And so the bigger the droplet, probably the bigger amount of virus, and therefore the more infective. And so this is pertinent to not only surgery, but also how we work in clinic, because how an aerosol behaves in the room will depend upon a number of things. So when we produce an aerosol, a human does it all the time, and it'll depends what we do, what aerosol we produce. So if we produce, say, from breathing or sneezing small droplets, those less than 50 micrometers remain airborne in the atmosphere, but evaporate quite quickly within 2 seconds. However, larger droplets may travel up to 2 meters before landing on surfaces. So it's interesting to look that breathing has the lowest velocity and the smallest droplets. Sneezing, the highest velocity, they can travel up to 6 meters with small and large. But even more interesting, that talking produces aerosol actually more than coughing. And so the larger the droplet, the higher the viral load. And so if a large droplet can travel 2 meters, that's why we have social distancing. Now, in terms of surgical aerosols, it's been known for some time that COVID-19 exists in high concentrations in the lining of the nose, the lungs, and the throat. Now, the middle ear is an outpouching of the nose, and so it is known that other coronaviruses have been found there, but we don't truly know if COVID exists in the middle ear. Now, when one does cochlear implant surgery, you use a high-speed drill to go through the mastoid with water for irrigation. And this produces a huge plume of a mixture of fluid, blood, bone, and more importantly, mastoid respiratory mucosa. And that may well carry COVID particles. The difficulty comes is we don't truly know the risk of COVID transmission for this mastoid surgical aerosol. However, we have to assume that it does have the potential for COVID to be transmitted, hence the concerns about mastoid surgery and cochlear implantation.
Thank you. So am I right in thinking that if the patient has been, I'm just thinking kind of preoperatively, if we can test everybody for COVID, and if they are COVID negative at the time of surgery, does this mean that the operating staff are at no greater risk, and the cochlear implant surgery can just proceed in a normal way?
So it depends when you're testing the patient, and also it depends what the false negative rate is. So currently the plans are in various units to test 48 hours before the operation and potentially a week before that. So you have a pathway of knowing how likely the patient is to be COVID negative. However, you don't know if the patient has contracted COVID or has potentially got pre-COVID in the few days before they come in. So we are getting much more information about the patients, and it's becoming far less of a risk of having a COVID positive patient. However, we cannot rule that out entirely, and so we actually need to reduce risk in the operating theatre as well if we can.
So as far as I understand, with the NHS testing, you need to have the test within like 3 to 5 days of first getting COVID symptoms. Otherwise, you might not get an accurate response. So will you be proceeding and assuming that everybody is COVID positive?
So all trusts have different policies, but most trusts will first of all, ask all patients to self-isolate if they're an elective patient for between 10 and 14 days prior to surgery. Secondly, they will be tested for COVID, even if they are asymptomatic, at least 48 hours before the surgery, and in some trusts, both at 7 and 2 days before surgery. So you are testing the asymptomatic elective patients to make sure, well, to try to make sure they are COVID negative.
Thank you. We've just got a couple of questions actually, Tim, on what you were talking about. So Hugo Fitzgerald has asked a question, and his little boy is waiting for cochlear implant surgery. And as you said, the guidance is up to a 3-month delay for a prelingual baby. How much will this vary from hospital to hospital? How much is it kind of a trust mitigated guidance, or is it nationally implemented? Tim, do you want to answer on that?
I think the first thing to say is that the document that was produced by the 4 Royal Surgical Colleges was very much a guideline, and it was done in recognition that there would be competition, as it were, between different surgical specialties for limited resource in terms of theatre space, and to give a framework under which that could happen to allow hospital trusts to recognise the degree of urgency across different specialties. It was produced fairly early in the crisis, and it's obviously views on that can change with time. And I think it's fair to say, when this all started, that we had rather hoped that within 3 months we might be getting back to rather more activity than we have done. So there will inevitably be some variation across trusts. That will depend to some degree on their local facilities. It will depend upon how much that individual hospital has been affected and continues to be affected by COVID. And will depend also to some degree on their pre-existing waiting lists. There are some other issues, I think, which we're going to come on to around intraoperative issues, particularly around protecting the surgeon during surgery, which we haven't entirely solved yet, unfortunately. And I think that reflects the fact that, therefore, we haven't really seen a significant increase in mastoid or cochlear implant surgery as yet.
Thank you. And Hugo, we do recognise this is a heartbreakingly difficult time for families of babies who are waiting for a cochlear implant surgery, when of course we know that we really want to give the child access to sound as soon as possible. Manohar, can I just bring you in here? We've got a question from Tracy, and again, this is all to do with prioritisation, of course. And do you think there is any scope? I mean, like Tim says, all the specialties are competing on the prioritisation, but do you think there's any scope for adult patients and non-preverbal children to move from 4 to 3, or you think there's little chance of that? Can I just unmute? Can you just, that's it.
Yeah. sorry, as you say, everything's in competition with each other, and as you know, we have to show that there is a significant long-term disability towards moving to greater than 3 months, under 3 months, if you didn't operate within 3 months. That might be difficult unless there's some kind of failure of the implant, or there's some kind of change in function, or there's deterioration in the language ability of the child, or something like that, or of infection, obviously. I think it'd be difficult to make a case that a 1 month delay would make a difference in long-term outcomes in many of these cases, particularly because you're looking at many other surgeries, like, you know, many other specialties that have very similar issues. So we would have to fight our corner to try and to do that. It's not because we're not just our patients, which we have very much in mind. It's our patients in the context of everybody else's patients in the whole healthcare system.
That makes sense, yeah. Simon, can I bring you in here? We've got another question. Thank you so much for the questions. So in terms of screening patients preoperatively, when it's children, or indeed with adults, will the family members be screened as well, or will it just be the patient?
So the current advice is that one of the parents needs to self-isolate with the child, so not the whole family, but
right.
That has its own difficulties because other members of the family may be coming in and out to go shopping or to go to work, and you can't really isolate completely. So I think we have to be slightly pragmatic on that point. And then the other issue with children is that actually they're quite difficult to test. You know, we can't really get a nasal swab from a young child, so we can't necessarily get a reliable swab result in advance of the surgery. So some centres are swabbing the throat, which will give us some idea of whether they're positive or not, and just accepting that there will be some degree of limitation.
That makes sense, thank you. We've got a couple of other questions, but just in the interests of time, we might come back to those later, if that's okay. So we know what the risks are, we understand about the aerosol. So in terms of cochlear implant surgery, what can we do to minimize the risk? What on earth can we do? So Will, do you want to start on this?
Certainly, thank you. Helen, could we have the slides again, please? We can go to the first slide, please. So in the operating theatre, we are trying to prevent transmission usually from the patient to the staff, but of course the staff want to prevent infection of the patient. And so there are 3 ways that COVID can be transferred. One is through the lungs, and actually a lot of this has been sorted out with the new masks, the FFP3 masks, or alternative. We can try and contain the aerosol, and there have been innovations in containment draping. COVID can also enter the body via the eye, and in the community this can be due to touching COVID droplets on the surface and touching your eye. And this is the one we're struggling with most. If I can just go to the second slide. In Southampton, we described what we call the Southampton tent in mid-April, when it became apparent that we might have to operate on patients as an emergency. And this is using a special microscope drape, or a second microscope drape, that we place over the patient. The patient has a tube in their lungs to allow them to breathe, so they're not reliant on the oxygen. And so putting a plastic bag over their head doesn't cause a problem. And then we can operate under this, which catches the aerosol to prevent it going into the operating theatre. Now, this is published on the ENT UK website and has been also passed through the British Society of Otology. Since then, there have been iterations, and in London at UCL, a further drape has also been described, and we can put the link up on the BCIG website. And in America, they've also had similar thoughts about how to try and contain the aerosol. And there's a paper on the next slide, if I can put that up. And this is a letter in the Journal of the American Medical Association. So in terms of containing coronavirus aerosol, we seem to be making strides forward, although none of this is perfect. The surgeon and the staff need to protect their eyes as well from aerosol. And this is the main issue, because in order to use a microscope, you need to look through the eyepieces. So if I have the next slide, and this is actually me operating on a case very early on in the COVID crisis, using a tent, but also using a powered respiration hood that actually filters air. But the issue is getting your eyes close enough to the microscope to be able to see clearly. And there's work from Bristol that's due to be published, which shows the further the eyes are away from the microscope, the less field of view you can see. So we can protect, however, can we see enough to safely do the work? And currently, this is the biggest area that needs work on.
Thank you. And Tim, is the cochlear implant surgery, it's obviously very risky to the surgeon, the operative staff. Is it more risky to the patient at this time? And does that have any implications in terms of the patient's consent process for cochlear implant surgery?
Yes, that's very important. I mean, clearly there's been a lot of focus around PPE and protecting staff who are in contact with people who are known to be COVID positive or potentially COVID positive. And although we're starting to talk about COVID green and COVID blue patient pathways, clearly we're going to have to continue to assume that patients may be COVID positive. But we mustn't overlook the potential risk to the patient. There was a paper published in The Lancet last week collecting together data from around the world, patients who had had surgery who were COVID positive, either known to be positive prior to surgery or contracted COVID in the immediate post-operative period. And the findings were that 50% of those contracted, developed pulmonary complications, so chest problems following surgery. And the mortality rate was 23%. Now, this is clearly quite a selective group, but it does indicate that the risk of having surgery in patients who are potentially COVID positive can be very significant. And although clearly we will screen out people who are symptomatic and those who've been tested positive, there is the possibility that patients will slip through who are unknowingly COVID positive. And that has to be included in the consent process. And I think particularly where there's no urgency for surgery, and having already acknowledged that some patients won't necessarily wish to come to hospital at all, that will change the priorities, I think, for patients as well.
Definitely, thank you. Manohar.
I just wanted to, in the surgical tent, were we going to show Rob Nash's contribution as well? That slide. We had different iterations of the tent. I just want to thank Rob for sending some of those slides, but there was those slides I sent you. Did you want me to follow on with those, because that follows naturally from Will's part?
Perhaps I can put those slides on BCIG website for unless you can talk briefly about them.
I mean, I just wanted to acknowledge that Rob did send some of those slides, and we perhaps didn't mention those. And so there are various iterations, and the main problem with all these things is that when you drape it to the lens, it tends to be very sensitive to tilting of the microscope. So when you drape it to a very narrow base, it tilts, it obstructs the view because the drape can get in the way. And the second part is that moving instruments in and out of the drape can be difficult, and so the Auto tent has cut slits into it. You have the UCL one has passing instruments in and out from underneath. The one that from Gosh that Rob Nash has developed is basically 4 drapes, one on each side with overlapping sheets, and basically allows you to go in and out fairly easily. But none of those are perfect. But I just wondered if it'd be worth. I just want to acknowledge that he had sent that slide, and there would be other iterations be worth putting that up. And to Tim's point, I mean, even the patients who had elective surgery had a 20% death rate in that study. So we're not just talking about selected population necessarily. Even people who had local anesthetic had something like 20% death rate. But these are very highly selective, I suppose, local ones. But I mean, there's a very significant risk from being COVID positive and having surgery.
Thank you. So obviously we have the draping, the eye protection, there's lots of things that have to be done differently. Simon, what else will you do differently during cochlear implant surgery? Will it take longer? Will you do things in a different order? Will you use different instruments? What's the plan?
Well, I think at the moment most people will continue to use the microscope, but there are certainly new technologies that have come about over the last 2 or 3 years that allow us to operate off a 3D screen, and they may become more popular as we get used to those sorts of things. And those will allow us to wear the hoods and have more effective eye protection. So that's one potential solution that may develop over time. But assuming we continue to use the microscope, I think we're going to have to be probably pragmatic about the eye protection for the moment. In terms of surgical technique, one of the challenges of using these tents is that you've covered the patient and you've done your drilling and you've filled that tent with aerosolized particles, and you then have to take it off, and that potentially releases the aerosol particles. And a lot of our surgeries up until now have involved doing a bit without the microscope, then doing a bit with the microscope, and then doing a bit without the microscope again. And I think we probably will need to change the order in which we do our surgeries to try and minimize the amount of taking the microscope on and off if we're going to be using these tents. So we may well do all of the drilling at the beginning, so drilling the well at the same time as doing the mastoidectomy, rather than doing the mastoidectomy and then prepping the drapes and all that kind of thing, and then coming back in again with the microscope afterwards. And I think what we do in theatre will change. On the anaesthetic side, there's delays in terms of letting aerosols settle after the intubation, so that will probably delay things by 20 minutes or so if we're waiting for that to happen. A lot of the hospitals now are extubating patients in theatre, so that will cause more delays. So we need to take all these things into consideration, and the number of cases that we're going to be able to do, I think, will certainly drop significantly because of all of these complicating factors.
So would I be right in thinking that if we had a surgery slot where normally perhaps our surgeon would do 2 adults, now it's going to be 1 adult for the moment?
I think fair to say that for the moment it will be. And things may change. We don't know what's going to happen with the COVID pandemic generally, and obviously the amount of COVID in the population is dropping every day. So we may find in a few months' time, all being well, that we won't have to carry on with these things and we can get back to normal. But I think for the moment, we're going to have to accept that the number of cases we get through is going to be less. And the other issue is working with the PPE. I mean, if you're doing a bilateral child, you're often talking about a surgery that might take 3 hours or so, and to be in a full face mask for 3 hours is quite challenging too. So yeah. I think we're talking about perhaps pairing up with surgeons so that one does one side, one does another, just to minimize the amount of time that you're wearing the PPE.
Yeah, I mean, like you say, Simon, it's kind of a fast evolving situation, isn't it? And that's been the case really throughout the pandemic, that every week really what we say goes out of date. So fingers crossed things will be a little bit easier in perhaps 3 months. And we've just had a comment from Connie saying it helps to do all the drilling with the microscope on, and then once the drilling is done, the microscope goes with the tent and the surgeon continues with the wound closure. So that will be the kind of different order you're talking about. Yeah. Yeah,
I mean, Connie's done a lot. Well, I say a lot, relatively speaking, compared to the rest of us, I think. So she's had a lot of experience. So thank you for that, Connie.
So I'm just going to put up Rob Nash's drape, which I'm sorry, it just got missed off what the presentation that we had before. So Manohar, would you mind just talking us through this quickly? Because I think it is important to see. Oh, sorry, that's not the right screen, is it?
Sorry, this is entirely Rob's.
Yep. I mean, we wanted to have Rob here today, didn't we? But it was just difficult to timing-wise, really.
I see in the meantime, there's a question about can it be transmitted through the eyes? While you're looking for that, well, there's no evidence for the SARS-CoV-19, but there is evidence for the original SARS virus, and there's certainly evidence that rhinoviruses and RCT viruses and influenza virus can be transmitted through the eyes, and there's feline coronavirus being transmitted through the eyes. And in the original SARS-1, there was a study in Toronto where they had a 7 times higher risk of infection without eye protection than with eye protection. The odds ratio was 7 times higher. So I think overall there is evidence that probably you can transmit through the eyes or through the touching of the eyes of secreted tears and things like that.
So this is Rob Nash's Drake Manohar here, isn't it? Yeah.
So essentially, this one is interesting because it's got a broad base to the 4 sheets, overlapping sheets of draping sheets, basically. And because it's got a broad base, if you tilt the microscope, the whole thing doesn't fold on itself and obstruct your view. And if they're overlapping, it's relatively easy, I understand, to get your instruments in and out. The downside is that when you're putting your instruments in and out, there is a small gap there that for that time that some of the aerosol could escape. But that would be true whether you cut holes in it or put them underneath the drape as well. But it's another interesting, slightly different in the sense that it allows you a much wider base and is a bit more resistant to tilting and things like that. So I think it's worth considering for those people who have it, who want to continue to do this thing.
Thank you. Will, what were you going to say?
So I think all the draping is, all the iterations, innovations are great. But I think as Connie made the point, within the drape, even when you take it off, you will have residual aerosol that is difficult to capture. And also you'll have dust and what they term fomites. So this is more solid tissue that is moved when you move the drapes. And so the trouble is you will have a layer of bone dust and potential droplets, potentially some fomites when you remove the drape. So the drapes are useful, but they are not the solution to actually stopping COVID transmission. And that's the issue. We're trying to reduce the risk as opposed to eliminate risk. And that's the biggest trouble. The only thing that will eliminate risk is when either we don't have COVID, which I think is now unfortunately unlikely, or we have a vaccination that is effective, or if you've had it and you're immunologically shown to be serum positive, whether that gives you true resistance and the fact you will not have it again. So I think we're talking about all these things we're talking about are reducing risk, not removing risk.
Well, it's worth pointing out that risk is not just to the surgeon, but the rest of the team. And what the drape does do is localize a risk more or less to the surgical area, to the surgeon. Even when you remove the drape, most of that risk is still to the surgeon. The surgeon's at risk, but you haven't spread the aerosol throughout the whole of the operating, well, within 2 meters of the operating site.
Which of course is the whole benefit of the tents. You are capturing, containing your aerosol containment, aren't you? Which is what you're trying to do. But I think it's worth pointing out, this is not a panacea. This is a way of containment. We are containing, not eliminating.
Absolutely.
Yeah. It's just a question from the audience. When we're thinking about the eye protection and the difficulty of getting close to the microscopes, somebody has asked, what about prescription swimming goggles? So presumably they would seal the eye area. Would that be helpful?
That has been used by some people. Mike Waring in Barts has tried that, and it's pretty uncomfortable after an hour or an hour and a half of operating with them on. It's quite difficult. And the other slight difficulty is that they're quite rigid, so you can't get your eyes that close to the microscope. And as we mentioned earlier, the further you're away, the smaller the view that you get. So it's pretty challenging.
Yeah, I think in that clamp study, there was you had to be within 20 millimeters of the eyepiece to actually get 70% of view, and 15 millimeters to get 100% of the view. So I've tried swimming goggles, and it's just difficult to get close enough to get 50% of the view.
The other issue is actually getting your nose in between the eyepieces of the microscope. And if you wear something too rigid, again, that keeps you away. So this is the biggest challenge.
That makes sense. We've had another question from the panel, from the attendees. David Salvadori is asking, and I'm not sure if you mentioned this with the study you were talking about post-operative risk. So David is asking, can you talk about the risks of COVID in the post-operative period as shown in the recent Lancet publication?
I think we talked about that.
Covered that, yeah.
That was the publication you were talking about, was it? Okay, good.
The only thing about that publication was that it combined patients who were known to be COVID positive prior to surgery and those who then contracted in the post-operative phase or were identified as being COVID positive in the post-operative phase. So there's a bit of a mixture of patients in there. But they did look at them according to the stratified in different ways. And the other important point that came out of that is that the mortality rate for those over 70 was significantly higher. And of course, for our adult patients, we have a lot in that category. So we certainly need to bear that in mind.
I've had another question from Shomeshwar Singh, and they ask, can we mix povidone iodine or a similar medication in the irrigation fluid to neutralize the virus as we drill? Is this a good idea? Who would like to talk on this? Simon?
Yeah, I think it is a good idea. I don't think there's any harm in doing that. I'm not actually aware of how virucidal povidone iodine is, but I'm presuming that it is just as virucidal as any other cleaning fluid that we use. And I think potentially it is a good idea.
I've tried it. Sorry, go ahead. I tried it. Sorry, you go ahead.
Right, Will, you start.
It's certainly something. I did a case or two. I've done a case of hot mastoids for infection, and we discussed doing exactly this because povidone iodine is known to be very virucidal, and so it's a very good antiviral agent. The issue is how much do you put in to be effective, and also what is the absorption by the patient. There's no doubt that when you do TURP surgery for urology and cut away the prostate, they use saline to irrigate, and the patient can actually absorb saline sometimes, leading to biochemical blood disorders. Now the question is how much iodine would be absorbed by the patient and how much of that would be harmful or not. I don't have the answers, and I don't know if Manohar, you have any thoughts on that?
Yeah, and that's a good point about a systemic absorption. I never really thought about that, to be honest, but it is very virucidal, even when you dilute it by a lot. I've done it for a translab, but we didn't put it in the irrigation flip. I just squirted it into the mastoid every on. The only problem with that, it does stain everything a lot brown, and it's really hard to see your landmarks because everything looks like this shade of brown, and then you have to wash it all out again to see. But if you had an irrigation fluid, I could see it would be less likely to perhaps stain. And you can apparently dilute it 20 times and still be virucidal. So it is a possibility to use. But I must admit, I had not thought about the systemic absorption risk. But there is also the other thing, the risk about it is that iodine is ototoxic. We don't give it in very large doses, but it is an explanted hair cells, for instance, is ototoxic. So if you're going to continuously irrigate and you're going to give somebody a continuous dose of it, I'm not sure what that does to the inner ear either. So that's something to think, another thing to think about.
Yeah.
Thank you. So we've talked a lot about the preoperative period in terms of quarantine, screening, the intraoperative period. What about postoperatively? So what are your plans for post-op check? Are people going to stay in the hospital shorter or longer? And if somebody does contract COVID during their surgery or during their stay in hospital, as you say, they may well be at a greater risk. So will you keep people in longer? Who wants to talk about this? Simon, do you want to start us off?
Yeah, I think it's always a good idea in the current situation to minimise the stay of patients. Most centres, I think, do their cochlear implants as day cases anyway now, which is a good thing. I guess the other issue is whether we change the type of anaesthetic we use. There's lots of people that have done local anaesthetic cochlear implants now, and leaving aside the high death rate amongst local anaesthetics as well as general anaesthetics in that Lancet paper, perhaps maybe the local anaesthetics will allow people to get up and about and out of hospital quicker. In terms of post-op follow-ups, and I think all of us are getting used to the idea of doing video consultations now, and actually I think the post-op check probably lends itself quite well. They can get a family member to take a picture of the wound, and other than that, most of the consultation is just done through speaking, so you can do that with a video just as well as you can face to face. I think that's something that people will increasingly do.
So Simon, it'd be difficult to do that kind of draping at the local where you completely cover the patient.
Yeah, you'd have to avoid that. You couldn't do the full tent.
One thing at the back of my head has always been that this could be a good segue into robotic surgery if we can minimize the mastectomy and have the trajectory and lined up with the cochlear implant, as they have done in many temporal bones and a couple of real cases, I think, even. So you have minimal incision, minimal drilling, and minimal stay in hospital, perhaps. So this could be an incentive towards that kind of surgery, perhaps.
Yeah, absolutely.
And that goes along with really, I mean, what I'm thinking about CI services in general, does it apply to the surgery? So the changes you're having to make now, are some of them going to be changes that you want to sustain long term? Are some of them going to be beneficial, new ways of doing things? Tim, what do you think?
I think the short answer is absolutely yes. I mean, we've focused a lot during the crisis on the negatives, but I think there definitely are some positives that have come out of this. Certainly the use of technology to communicate with people. Cochlear implantations run out of regional centres. That's involved patients travelling long distances in many cases. And so if we can minimise the need for doing that, if we don't need to have a face-to-face consultation, that's a good thing. And if we can do post-op checks and other appointments remotely, that's really good. I guess one of the things that we do need to think about is access to the technology. We have patients who aren't necessarily able to access the internet easily or have the necessary hardware to use these sort of facilities. And then the other important thing, of course, is communication, dealing with a population that's profoundly deaf. That doesn't make using these technologies necessarily very easy, and we'll need to have ways to minimise the difficulties associated with that. But yeah, definitely, I think there'll be many positives that will come out of it, which we need to continue with.
Thank you. So we've got just more than 10 minutes left. So I'm going to go through some questions we've had from the audience now. So we've had 2 questions from Joe Manjali, and one is about isolation. So Will, I'm going to ask you this. So I know you said when it's a child, one parent will have to isolate with them. What about other people that share a house with the patient?
So this is a difficult issue, and also has been dealt with by BAPO, which is the British Association of Paediatric Otolaryngology. And so there's a website which has recommendations. Generally, the recommendation is in a household, ideally, if a child's going to go in for surgery, the whole household should self-isolate for 14 days. Now, that's the ideal. However, of course, often there is one parent who may well have to work and will have to come in and out. And so the thought process in most trusts, and also from BAPO and DNT UK, is there should be one parent who self-isolates with the children, stays away from the other parent, who probably has to be separate, sleep separately, try and remove himself from the family for that 14-day period. But that's very difficult. And there are other children who will want to play. So I think you have the ideal, but it is one of the issues with paediatric surgery is you often can't control how a child acts and always behaves. I know that as a parent myself. And so therefore, there is a possibility that, especially in children, a child may have COVID with either symptoms or be asymptomatic, and it is more asymptomatic in children, but be carrying COVID, and because they haven't been able to totally self-isolate, you can't take a swab, probably the risk of an asymptomatic child with COVID coming for surgery is slightly greater, but you can only do what you can. BAPO has suggested that probably it is worth with children, because the best swab is a nasopharyngeal swab, is to take a swab on table. So when the child's asleep, is to re-swab using a deep nasopharyngeal swab to actually see if the child is negative or not with a proper swab intraoperatively, because then at least you will know either way, hopefully, if that child is positive or negative. And if positive, you can therefore watch them much more carefully, and that helps with post-operative planning.
Thank you. And just following on from that, really, so are we going to have more of a problem with last minute cancellations of surgeries? Are we going to have more people kind of on on the waiting list who will accept a surgery date at short notice? Maybe how on earth will that work? So if we cancel someone 48 hours before their surgery, we can't really offer that slot to somebody else because they haven't had that quarantine period. Are we going to end up with lots of empty slots? How will this work?
Potentially, yes. Unfortunately, at this current stage, potentially, yes. I suppose as testing gets better and possibly point of care testing occurs, then we can be more certain that a patient is COVID negative. However, I think at the time it is the nature of the beast that if a patient does become asymptomatic and has a positive swab at 48 hours, that theatre slot unfortunately may be wasted for that surgeon, although often in hospitals there's a lack of theatre availability. It may be emergencies or other cases can go in. So often the theatre is used, but not for what it was planned for.
Yeah, it is difficult, isn't it? You know, we're so worried about our waiting lists anyway, but things are kind of confounding together really to make things even more difficult. Manahar, we've got a question for you here from Neil Donnelly. And do you think that because the theatre staff are going to be wearing additional PPE, do you think we might see less incidence of post-operative wound and implant infections? Could this be another benefit of the stringent measures we're going to be taking?
Could be. Actually, it'd be fascinating to watch this, wouldn't it? I think this would be an absolutely fascinating study to look at the incidence of post-operative cochlear implant infections in the COVID era, when everybody is really minimizing the effect of transmission from each other. We haven't really taken the approach that perhaps orthopedics has in cochlear implant surgery of really using negative pressure theaters and absolutely taking sterility as seriously as some other specialties that do implants. There could well be a positive from this, in that we see reduction in cochlear implant early stage infections. And this would be absolutely fascinating to follow up. It's a great question.
Yeah. And just another, so Tim, can I just ask you another intraoperative question? So what do you think about avoiding the niche in the bone, drilling the implant space and using only the periosteum pocket? That's a question from Marcella Marchena.
So I think in the UK, most of us now use a periosteal pocket to put the package into, rather than drilling a well, as used to be the sort of standard technique. But whichever you do, there's a need to prepare the pocket in preparation for the package to go into it. And as we said earlier, I think we will find that we'll all want to change the order in which we carry out the procedure, so that the period of time that we're generating aerosol occurs in one block within the operation, and then we can dispose of that tent trying to contain the aerosol before we complete the operation.
That sounds a good idea, thank you. So we've had a couple of questions about data collection in the perioperative period, infection rates, and actually, do you think this could be a another important use of the cochlear implant registry that we're setting up. Do you think this is going to be ready? Are we able to track this perioperative data in time? What do you think, Manohar?
Well, how far along is it? My understanding is not ready to accept that kind of data at this point. But maybe this will accelerate our impetus to try and do that, because it would be, if we start moving out of this phase and moving into regular surgeries, then we could see the transition to perhaps what the benefits were of all this increased protection, things like that. It'd be an interesting time to start, because we've moved from completely one type of practice to another type of practice. But my understanding is that and you know more about this than I do, Helen, I don't think we're ready to start accepting that data in the registry yet, are we?
No, I don't think so. But it's a really good point, and I think if we can, we've got a good experience in the UK of collaborative working, collaborative data collection. So I think this is another time that we can all collect data together. Just a quick question here, which is going to involve a hand raise from the panel. So given all the risks that you've talked about, the risks which are mostly to you, which of you are happy to do cochlear implant surgery tomorrow? Okay, so 100% of you, thank you. We have had a couple of questions as well, talking about, obviously we know for children that we want to offer an implant as soon as possible, but also we must remember in terms of risks, the risk of dementia to adults with hearing loss. It is great if they have a hearing loss, and of course now we have isolation, social distancing, and the fact that adults are going to be waiting longer for their implant surgeries, of course, may well have an implication on that, and is possibly something that we could look at. And Nicole has asked here, would it be good to do a cost assessment on the risk to older adults and see if delaying their surgeries even more is going to end up with a greater cost to the state? Anybody have any thoughts on that? Tim?
I think it's an extremely good point. I think it's already recognised that the prioritisation that's occurred dealing with COVID has had unexpected consequences for patients with a whole range of other conditions. And clearly we're going to be in a situation where we can't provide care to everybody as quickly as we would like to. And that will have an impact upon many of those patients in many ways that we don't even recognise at the moment. And some of that will only become clear with the benefit of hindsight. But that's just one aspect that needs to be taken into account. And I think our real concern is that around the adult patients, particularly over the next few months, I think we're going to find it very difficult to get theatre space to deal with, to operate on those patients. And of course, that also doesn't take into account the fact that the other aspects of care in terms of assessment and rehabilitation afterwards we're also going to have limited capacity because of the issues around social distancing in clinics and PPE and so forth, which I think you're going to cover in another webinar. But there's going to be a whole host of things, some of which we haven't really recognised that come into play. But I think it's an extremely important point. We mustn't forget that. Yes,
just to follow on from that, Tim, thank you. We are, the BCIG is planning a follow-up roundtable in a couple of weeks. And at that point, we're going to be looking at the clinic-based appointments for adults and children with cochlear implants. So how on earth are we going to manage assessment? Who are we going to prioritise? Who is going to have remote care? Who's going to come to the clinic? So please, yeah, we'll publicise that as soon as we can. But please join us for that roundtable as well. Will?
I was going to follow on from Tim's point, and this is looking at the Lancet study. Now, the Lancet study that looked at perioperative deaths found there was a greater number in those over 70. And I think this comes into consent as well. There is, of course, a risk of Alzheimer's from not having auditory stimulation. But I think when we talk to a patient about the risks of coming into surgery, on the data we have at the moment, there is if they get COVID, something like a 20% risk of death, which is quite significant. And I think that the data is not all there. A lot of these patients were emergency patients, but we do have to be honest and transparent in terms of consent process for these patients. And I think that is important as well.
Thank you, Will. Yes, we've just got time for one more question before we wrap up. And this is from Joe Toner, and he is asking, in terms of surgical prioritization, what about sequential bilateral implantation? So he's giving an example of a child that they implanted just prior to COVID, who has mild learning difficulties, is doing well with the first implant, but they had agreed that they would sequentially implant the child. So how urgent is that case? Where does a sequential bilateral sit in the prioritization? Tim, you're smiling, so I'm going to ask you.
Yeah, that's a very good question, Joe. Thank you. I guess one can argue on the one hand that the child's now getting some sound input from its first implant, so that's obviously a benefit. And probably we'd want to prioritise those children who are waiting, who haven't had an implant at all. But there's going to be a juggling act, isn't there? Because we're going to be struggling for theatre space, I think. But that's not a child that you necessarily want to leave forever. But on the other hand, we also recognise that we turn the clock back. There was a period of time prior to NICE guidance in 2009 that many children were getting one implant, and we were pleased to be able to offer that. So I think one can argue either way. I think it almost certainly depends on what local resource you've got and what the pressures are on the service.
Thank you so much. So we've reached 6 o'clock, and I think it's time for us to wrap up now. So I want to say a big thank you to our panelists. So thank you so much, Will, Manohar, Tim, and Simon. Thank you so much to the attendees as well. So we've had around 125 attendees, and I think it's been very stimulating to see your questions and your input, and it's really made us all think, and perhaps even opened up more questions and more things for us to think about. If people have got questions that weren't answered, perhaps you could email them to BCIG, so info@bcig.org.uk, and we can try and answer them then. But again, thank you so much, everybody, for participating, and please watch this space for our next roundtable in a couple of weeks. Thank you. Good evening.